Welcome to AETCM, the Emergency Medicine channel. I'm Shanghaz.
Yeah.
A 50-year-old male, known case of type 2 diabetes, CAD, presents to the ER with complaints of headache of 2 hours duration. On our initial 10-second assessment, patient conscious and oriented. Coming to airway was patent, no pooling of secretions, no hoarseness of voice. Coming to breathing, air entry bilaterally equal, respiratory rate of 24 per minute, saturation of 97% in room air. Coming to circulation, BP of 200/100 millimeters of mercury, pulse rate of 90 beats per minute. All peripheral pulses were equally palpable. 2 large bore IV cannulas were inserted during this point of time. Coming to disability, GCS of 15/15, bilateral pupil equally reacting to light. Coming to exposure, temperature of 98.2 degree Fahrenheit, GRBS of 160 milligram per deciliter.
So, elderly patient comes with headache. So, what are the differential diagnoses?
Most common diagnosis can be any tension headache, any migraine, any cluster headache like that.
So, how will you differentiate between migraine, tension, headache?
Tension headache, usually that's the most common cause of headache. Usually a band-like sensations over the frontal region. Stress, anxiety can be the precipitating factors. And it does not affect the activities of daily living. Whereas migraine, usually it is unilateral. There can be aura, there can be recurrent episodic attacks. There will be precipitating factors, and that all points to migraine.
So, migraine, it will be, as you told, it will be unilateral. There will be aura, there can be associated photophobia, phonophobia, nausea, vomiting and all. And sometimes there can be some weakness also. Because of that aura, there can be some limb weakness or anything. And usually it will subside within 24 hours. Whereas tension headache, as you told, it is like a band-like sensation. And usually it is associated with stress. So, if there is any change in job or something, or exposure to a new environment, there can be this thing, and it might last for some days in the sense every day it will be there, towards the evening that will be there, and it will not like subside within 24 hours. For every day, for some period of time, that will be there. What about cluster headache?
Cluster headache, usually it is also episodic. Frontal region can be most commonly seen, and severe headache, it is usually cluster headache.
What is special about cluster headache is because of the eye involvement. There can be some watering of the eye, redness of the eye irritation and all can be there in cluster headache. So these are the different types of headache. So how will the treatment vary?
Usually tension headache, we can give any amitriptyline antidepressants, NSAIDs for acute attack can be given. For migraine also, for acute attack NSAIDs can be given, and for prophylaxis we can give amitriptyline, triptans, other drugs can be given.
So migraine is actually a vasodilation in the head. So what can be given other than NSAIDs? You should give an antiemetic also. And for vasoconstriction, in cluster headache and migraine, you can give oxygen supplement so that there can be vasoconstriction. So oxygen per se, oxygen therapy is the treatment of choice in cluster headache, but that can also be used in migraine. Okay, so other than headache, what are the other differential diagnoses other than this?
Can be hemorrhage, hemorrhagic stroke can be seen, like subarachnoid hemorrhage. There can be thunderclap type headache can be seen. Weakness can also be seen. And associated with any fever, vomiting and stuff, we have to suspect meningitis as part of headache, or any trauma related can be present, or in this case it can be raised BP due to hypertension. There can be hypertensive encephalopathy like symptoms that can lead to headache.
Press can be there. Okay, then. And in acute angle closure glaucoma also in headache can be there. Okay, in females?
Menorrhagia.
Females, because of menorrhagia, there can be dehydration and headache can be there. In pregnant ladies?
Eclampsia.
Preeclampsia can present with headache. Okay, eclampsia means seizure activity. Okay.
Preeclampsia also.
Okay.
At this point, the pain score was 6/10, and injection paracetamol 1 gram IV stat was given at this point of time. Coming to adjuncts of primary survey.
So this patient is having headache. So it either patient's the high BP is because of the headache or because of the high headache can cause high BP and high BP can cause headache. So first we are treating with analgesics. Okay. So do you think it is hypertensive urgency or emergency?
This is a case of hypertensive crisis because BP is more than 180/110. That can be divided into again two types: hypertensive urgency and hypertensive emergency. In case of hypertensive emergency, there should be target organ damage. Based on
like examples,
like target organ damage, like there can be LVH can be the case of CVS like symptoms, can be severe stroke in the case of CNS. Encephalopathy like symptoms, hypertensive encephalopathy. In case of CVS, there can be MI, acute pulmonary edema, acute heart failure can be there. In case of renal system, there can be AK and also aortic dissection.
AK, nephrogenic pulmonary edema, worsening of creatinine can be there.
These are the this causes target organ damage and examples of hypertensive emergencies.
Okay. One more thing we missed in headache differential diagnosis with high BP is pheochromocytoma. That can also be there. Okay. Hypertensive urgency. What do you mean by a hypertensive urgency?
Hypertensive urgency means there is more than 180/110 BP without any target organ damage. There can be symptoms, but there is no target organ damage as such. It is most commonly due to primary hypertensions.
Okay.
Whereas in hypertensive urgency is mainly due to secondary hypertension. It is unless proved otherwise.
So this patient might be in hypertensive urgency or emergency?
As of now, there is no indications for target organ damage, just headache, and we give an injection paracetamol 1 gram IV stat, and we will reassess, and if the patient improves and there is no other adjuncts also showing if there is no other worsening of anything, lab parameters are normal, then it might be a case of hypertensive urgency.
Okay, so in the since in the cardiovascular system we didn't get any pulmonary edema features or there is no disability as such, so there is nothing pertaining to any hemorrhagic or ischemic stroke or something, so we feel it is hypertensive urgency, and sensorium is also okay. So that's rules out a press also. Okay.
Coming to adjuncts of primary survey, we did an ECG. ECG was showing only sinus tachycardia, no features of any LVH, and no acute STT changes.
You told you place 2 large bore IV cannula. Now, what all samples will you take?
We can take a VBG. Since we are having a multifactorial VBG, we can get the potassium acidosis, acid-base status, and also creatinine status can be get. Then we will do an RFT, which can also show the renal status of the patient, CBC, CRPs, and
CBCRP to rule out
infections. And also we can give for other samples for endocrine like thyroid function test. There are secondary causes of hypertension, like in case of renal involvement, there can be thrombotic microangiopathy, there can be hemolytic uremic syndrome, renal artery stenosis. In thrombotic microangiopathy, hemolytic uremic syndrome, we can send a peripheral blood smear. We can look for the schistocytes as such, and thrombocytopenia CBC indicative of.
There's no need to send now based on if there is patient is suspected to have a elevated LDH or any hemolysis features, or patient is having some altered sensorium and we are suspecting something like a TTP, then only you will have to go behind that. Okay.
Then we did a VBG at this point of time, which show a pH of 7.40, PCO2 of 40, bicarb of 24, lactate of 1.6, potassium of 3.8. No acute acid-base disorders were noted at this point of time. Then we come to the sample history. A 50-year-old male, known case of type 2 diabetes, CAD, present to the ER with history of headache. It was a tension band type headache, which has no radiation, and it persists for a few hours throughout the day. It was not episodic in nature, and also it does not affect the daily activities of living. There was no history of any weakness, no history of any trauma, no history of any altered behavior, head vomiting, no history of any breathlessness, no history of any chest pain or backache, no history of any decreased urine output or hematuria. No history of similar illness in the past, but the patient is a known case of chronic smoker and alcoholic. No history of any weight gain or weight loss. No history of any similar episodes in the past. History of drug intake for type 2 diabetes, he is taking metformin, and for CAD he is on antiplatelets. Last meal was 2:30 p.m. Coming to examination, no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy or pedal edema. BP was recorded in all the four limbs, and there was no variations in the BP.
Why did you check that?
In case of any aortic dissection or in coarctation of aorta, there can be variations in the BP.
Okay. So suppose you are finding there are some variations in the limb BPs. How much difference will you take it as significant?
Systolic BP more than 20 between
more
the
than
limbs.
more than 10 you can take it as significant. And when will you suspect, so if you are suspecting like an aortic dissection, and if you are getting an screening a aortogram, or screening aorta screening, if you are getting some abnormalities, how will you reduce the BP?
In aortic dissection, we need to maintain a systolic BP of 100 to 120 at the earliest.
Heart rate?
Heart rate can be, we need to avoid tachycardia in this case.
So you can keep it, remember it as 80. So keep a heart rate less than 80, and try to keep systolic BP also. We need only 80. We just imagine it as like we keep permissive hypotension in case of abdominal bleeds. Like, so one hypotension we can maintain in this. So systolic BP is also requirement is only coming around 80, that range. Okay. Map. So the map will be somewhat coming between 55 to 60. That map is required only. So 80. BP and heart rate less than 80. 80 or less than 80.
Then we come to systemic examination. CNS GCS was 15 by 15, bilateral pupil equally reacting to light, moving all four limbs. CVS S1 S2 were present, no murmurs. Respiratory system air entry bilaterally equal, normal vesicular breath sounds, no added sounds. GIT abdominal was soft, non-tender, and bowel sounds were present. So the initial diagnosis was this is a case of hypertensive crisis with hypertensive urgency.
This patient abdominal examination, you will have to check for renal bruit also, renal artery stenosis. Okay.
So diagnosis was hypertensive urgency. So we started with oral antihypertensives. As per the new guidelines, beta blockers are not used in oral treatment of antihypertension as first line because it does not decrease the central systolic blood pressure. So we started with ACE inhibitors or ARBs. We given telmisartan 40 mg and wait for half an hour. Our target was to reduce.
What is the age of this patient?
Age was 50.
50, okay. If this patient is having some renal failure and all, try to start with a calcium channel blocker. Okay. Since that is not there, you can start with AC inhibitors or ARBs. What did you start?
We start on telmisartan 40 mg, stat dose was given. And our target was to keep a mean arterial pressure less than, to reduce the mean arterial pressure by 10 to 20% in the first 1 hour. And then 5 to 15% in the next 23 hours. As in the case of emergencies.
So this patient is having a hypertensive urgency. So what will happen if you reduce the BP very fast in hypertensive urgency?
If you reduce, there is a mechanism of auto-regulation. That is, the perfusion to the major organs will be affected if it drastically reduces the BP. So there can be J-core phenomenon like phenomenon. If we drastically reduce, there is loss of this auto-regulation that can lead to cardioembolic or renal involvement issues.
Okay, so ideally in hypertensive urgency, you need to reduce the BP over 24 hours only. Hypertensive emergency, as you told, in the first hour you can reduce 20% of the BP. Then in the next 6 hours, you can reduce the BP gradually around 160, 100 that range, and after 24 hours you can bring the BP to baseline. But in hypertensive urgency, that's why we are using oral tablets in case of hypertensive urgency. Means orally we can treat. Hypertensive emergency we will have to give IV. Okay, so you started telmisartan for this patient. How did the BP improve?
The BP came down only to 210/110 after initial dose of oral antihypertensives. We repeat the BP after half an hour, and this was the value. So,
Will you expect a BP reduction with telmisartan within half an hour?
no, it will take at least 1.5 hours for oral antihypertensives to act. We then repeat the BP again after half an hour. Then it came to 200/110. Then we again repeat the BP. We charted the BP every half an hourly. Then again it came to 210/110. So at this point of time we have given calcium channel blocker, and then we again repeat the BP after 1 hour. It came down to 190/100.
Okay. When all will you use labetalol?
Labetalol is used in the case of hypertensive emergencies. First, the contraindication of labetalol is like COPD, asthma patients, heart block patients, hypertension patients, bradycardia patients. In those cases, labetalol is relatively contraindicated. Other all cases for hypertensive emergencies, we will give labetalol. Labetalol we will give initially a start dose of 10 to 20 mg over 10 minutes. Then we'll wait for another 20 minutes for its action. Maximum dose can be given as 300 mg. We can then start the patient on infusion like 1 to 2 mg per minute can be started.
1 to 2 mg per minute. So how will you load labetalol infusion? 1 ampule of labetalol will contain how much labetalol? 1 ampule will contain how much ml? Tell.
4 ml.
4 ml. 1 ml. 1 ampule will contain 4 ml. That is equal to how much mg? Stat dose.
10 mg. 20
mg. 20. For 4 ml is equal to 20 mg. So in order to start infusion, labetalol infusion, as we dilute in case of pan infusion and all, we won't dilute labetalol. Labetalol is usually does not diluted. So labetalol, if you want to start as an infusion, how much labetalol will be required? We will have to at least take 4 ampules. 4 ampules, so we will be taking in a 20 cc syringe. So 4 ampules means 4 into 4 ml, so 16 ml will be there. So we will take a 20 cc syringe, load that, and if you are planning to start as you told 1 mg per minute, so that will be total 60 mg per hour. So it will somewhat correspond to 12 ml per hour. So you will have to start it as an infusion of 12 ml per hour. Okay, so we told that this things we are taking a 20 cc syringe, in that 16 ml is there. So each hour we will have to give 12 ml each. So that 20 cc syringe, so we need more and more labetalol because every hour almost a syringe will get over. No. So and if you are increasing it to 2 mg per minute, then that means you 24. Will read at least 24 ml per hour. So you need more than 1 syringe labetalol. The more than 4 ampules of labetalol will be required. Okay. So when all will we use hypertensive emergency, especially in case of
CV, hemorrhagic stroke.
Hemorrhagic stroke.
And
ischemic stroke when you are planning to thrombolize
the patient.
Then
pulmonary edema.
Cardiogenic pulmonary edema, better to use NTG. Why?
Vasodilatory effect is also.
It is arterial and venous vasodilatory effect is there. So the coronary perfusion will improve. So better to use NTG. Other one more use labetalol. You can use in aortic dissection. Then you can use in pregnancy. In case of preeclampsia, we can give it as 20 mg. We can give as a bolus dose. Then we can repeat BP. In pregnant ladies, we will have to bring down BP as early as possible. So initially you can give it as a 20 mg stat. Don't wait for the 20 minutes. Within 10 minutes you can repeat. You can double the dose. So 20 mg you can give, then 40 you can give, then 80. Maximum 80 up to a maximum of 300. Anyway, maximum is 300. Okay. So you told about NTG. NTG, when will you use NTG infusion?
Mostly in the case of any MI, cardiogenic pulmonary edema, for vasodilatory actions that we will give.
Can you use NTG in IC bleed?
No, due to vasodilatory effect, it is relatively contraindicated.
But if the patient is going into bradycardia, if the patient is having bradycardia, then you can use NTG. Okay. How will you take NTG infusion?
See, we start like 5 mics, and then every 3 to 5 minutes we will double the dose. till the BP
So
comes.
NTG infusion, usually NTG will be coming as a 10 ml ampule. So that will be mixed with 40 ml of NS. So we need a 50 cc syringe, and we will be starting as 5 microgram. We will be starting as 5 microgram, which is almost corresponding to 0.3 ml per hour. And then when will you reassess the BP?
Every 3 to 5 minutes.
No, NTG will take some more time to act. So
Every 10 to 15 minutes.
every 15 minutes. Labetalol 15 to 20 minutes, NTG 15 minutes. Every 15 minutes we will have to reassess the BP, and then we will have to titrate NTG. So if we are starting it as 0.3 ml per hour, then we will have to increase to 0.6, 0.9, like that. So NTG, what is the maximum we can give? If we are starting it as 5 microgram per minute, that is equal to 0.3 ml per hour. Like that we can increase up to maximum 250 microgram per minute. Okay. But what is the problem with NTG?
We need to taper within 24 hours. It can lead to tolerance and tachyphylaxis.
Tachyphylaxis can be there. And what is the most common side effect? Headache. So in this patient, if you are starting, if at all it is an hypertensive emergency, if you are starting NTG, patient's headache will worsen. Okay. Then what happened?
Then we monitor the vitals every half hourly, and the BP came down, and it came to 180/100 and was stabilized with that. And we send the routine investigations and to find the cause of any target organ damage was there. And it was found to be normal. So we take it as a hypertensive urgency, and it's due to primary hypertension. And we send back the patient after 20 to 48 hours. Admission was done, and 20 to 48 hours patient was done.
So in the during the admission, along with the reduction in BP, what else you will have to evaluate?
The other causes of secondary hypertension.
Secondary hypertension like hyperthyroidism, pheochromocytoma. If it is a young patient, we will have to rule out renal artery stenosis with renal artery Doppler. And then what else?
This is since the elderly patient, we had to also he was also obese patient. You have to look for OSA component also. Sleep study if required need to be done.
During the admission, we can't do a sleep study, but definitely 2 things we'll have to do for sure.
Echo has to be done.
What will you look in echo?
Ventricular hypertrophy, LVH component is there or not. Then
hypertension is associated with diastolic dysfunction, so we need to look for the diastolic dysfunction also. Then one more.
24-hour urine sample for any urine albuminuria can be done.
Urine albumin can be present if it is a long-standing hypertension, and one more thing will be present. If it is long-standing hypertension, patient might be having concentric LVH. Along with that,
papilledema can be there. Fundus examination.
No, papilledema, it's not. Hypertensive retinopathy changes can be there. So we need to, before discharging the patient, we need to look for the hypertensive retinopathy changes. Then if at all changes are there, that means that patient was having hypertension for a long time. It was not diagnosed. So we'll have to document that. We'll have to bring down the BP, and during follow-up, we will have to reassess the retinopathy features, whether it is improving or worsening. Then what was done to the patient after 48 hours?
48 hours, the patient was admitted for 2 to 3 days, and everything was evaluated. The cause of secondary hypertension was evaluated, and it was ruled out. And the patient was sent back home with telmisartan.
Okay. Thank you.